I'm here.
Please, can we start, or we wait a while for everybody to join?
I think we should start. We should stick to time as much as possible.
All right. Okay. So good evening again. The last and previous times we have looked at full black count results, and we have looked at the different parameters that can be measured by the analyzer, those that can be measured directly, those calculated, and how they are used. The other day we tried to look at how to use those things to make diagnosis, and we looked at the different cell lines. Red cell lines when they go up, red cell lines when red cells are reduced, white cells when they go up, white cells when they are reduced, platelet when they go up, platelets when they are reduced. And we try to say that there are important information that we will be receiving at the clinical level to help us make a diagnosis. And so we looked at things such as age, gender, ethnicity, etc. We looked at certain key findings such as thrombotic tendencies, organomegalics, etc., etc. And we said that these things, when we see, it tells a story. In our next step today, we want to look at what we call workups. And workups in hematology simply mean that what steps do we take? What different steps do we take? Or what different tests do we do in our hematology laboratory to arrive at a diagnosis? And we know for us in hematology, everything begins with the sample taking and how we handle the sample and how we do our analysis, whether we have QCs and all the necessary things in place for us to receive results. And we also learned that in hematology, the first thing, or what we call the screening test, will be our full blood count, followed by evaluation of a film. And so we want to talk about simple workups that involves a story that is told, or if you like, a clinical summary that is told. And looking at a clinical summary, we try to walk through the different tests to see whether we can arrive at a diagnosis based on the information we are going to get. And that indeed is all we have to learn to do when we want to make diagnosis in the hematology laboratory. Once you understand these things, we can transfer them into blood film validator of your analyzer result. And so I must say that you know already, we have to harness all of them and bring them on board. I would advise that we should learn about chronic diseases and what hematological changes there may be, because most of the anemias that we encounter are due to chronic diseases. May they be infectious or non-infectious or the malignancies. You see, when you even take the thyroid, and the chemist people know that, and someone has, say, hypothyroidism, how does it affect us in hematology? Triiodothyronine and thyroxine, they are potentiators of erythropoietin. And so if you have a situation where they are not there or their concentrations are compromised, then it is going to affect our hematology. It will present in hematology as an anemia. So I just want to say that all of these things, we need them to bring them on board before we can make diagnosis using a peripheral blood smears. Otherwise, all we'll be doing will be looking at white red cells and describing them. White cells, describing them. It doesn't mean there's an absence of a pathology. The fact that red cells look normocytic, normochromic, the WBCs look morphologically normal, platelets are adequate, doesn't mean there's no problem. There may still be a problem. That is why we need all of these things to bring them on board. So I have looked at a few questions. Maybe some other time there may be more.
Hello, Ms. Alote. Hello, Ms. Alote.
But we are looking at understand them. I hear a voice, please.
So the network ritual has started again.
The slide
Two
was
people
not
entered.
working, so that's why I call for your attention. And then if you can enlarge for us to see properly.
I'm using a phone. And so I've done my best to enlarge it. I wasn't showing the slide and I was talking generally. I just showed the first slide and it is a question. So the workups are questions that we are going to look at and see whether we can make a headway to make a diagnosis. That's what workups are about. Workups are just about the things that we do to arrive at a diagnosis. That's what they are about. And so I've tried to look at them just for colleagues to know that all the things that we know already are supposed to be brought on board when we have these discussions. All of the things that we know already, we need to bring them on board so that we can make diagnosis. And so I have cooked this story so that we bring on board our knowledge in medical science and see how we can use our knowledge in medical science to make a diagnosis in our hematology laboratory. So this is the first question I want us to look at. We have a 3-year-old child that was taken to the hospital on account of anemia. And as much as possible, we try to use the problem because that is how we are going to encounter anemia. The easy read the first sentence. Hospital on account of anemia, easy bruising, recurrent infections. I want one of you to tell me what we should be thinking. Please, let's do it quickly so that we can run through some of these things such that we won't spend too much time on one question. So please, quickly, someone should help us here. There's anemia, there's easy bruising, there's recurrent infections. What should be our thinking? I want it to be interactive, please. Or you can't hear me. Please, can you hear me? Am I being heard or am I talking to myself?
Yes, please,
Hello?
we can hear you.
So please, let's move.
Okay, I can hear you.
Yeah, so please, I'm asking, if there's anemia, there's easy bruising, and there's recurrent infections, what comes to our mind? Quickly, let's move ahead. What comes to mind when we say a patient is anemic? What comes to mind? The patient is bruising easily. What comes to mind? Having recurrent infections. What comes to mind? All of these here are happening at the same time. If we begin to understand these things, that is where we can make diagnosis. But if we don't get to understand some of these things, making diagnosis becomes very difficult. Otherwise, all we'll be doing will be describing red cells, white cells, and platelets. And then we end there. We can't say anything else. So please, I'm asking, let's do this quickly. That someone is anemic. A child is anemic, has easy bruising, and is getting recurrent infection. Well, what generally will come to your mind? And I'm asking all of us, one of us can say that, because if I end up saying everything myself, it's not interactive enough for my liking. Then it means as if we are in the classroom and the classroom bit there. It's not the way I want it. We have gone past the classroom. There is no wrong answer here. So I expect people to talk. The other thing is that if I don't get anybody talk, I'm not sure whether I'm being heard.
Ms. Alote, please, you're being heard, but
Yes.
you find it difficult in reading the question, and some has entered into another side, so we will not be able to picture it very well. Earlier on, you actually Zoom it, and then it covered this presentation mode for us, and we're able to do it. But currently, it's very difficult for us to come out with this particular question. And then
are you also using phones myself?
I'm not using a phone. I'm using a laptop.
If you are using your phone, you can open up a bit, then you'll be able to read. I'm using a phone. So the best I can do is what I'm doing.
Okay.
If you are using a phone, I tried using a phone. So I have tried to increase the size on my phone. It's why I'm able to read. A 3-year-old child was taken to the hospital on account of anemia, easy bruising, and recurrent infections. No organomegaly was detected by the clinician. According to the mother of the child, this situation had been present at birth. Analysis showed mutations in the genes involved in the Fanconi anemia pathway. We have to perform a workup in the hematology laboratory to perform a firm diagnosis. We'll state the findings in each of the tests that we perform. These ones are the ones called workup. So you have a clinical situation. This is a hypothetical clinical situation that we want to deal with. So my only question was that, if you can hear me, if someone a child has anemia, at the same time has easy bruising, and at the same time has recurrent infections, what comes to mind? And this thing is audio, I'm speaking. So let's answer the question. Perform a workup in the hematology laboratory. What would be our first point of call? What test comes to mind first? What should we do first?
Hello?
Hello.
Yes.
Yeah,
Yes.
we're supposed to do a full blood count and blood film comment to check the morphology of the red blood cell and the platelet.
So we are supposed to, okay, let's take it one at a time. We'll do full blood counts.
Full blood count, yes.
We'll do full blood count. What would be your expectation?
The full
From the
blood to
history
check.
given, what
Hello?
expectation?
Yeah, that's what I'm saying. The full blood count, we are just checking to check if the person is having low hemoglobin, white blood cells, and the low platelet. Or maybe the MCV maybe.
Expectation, please.
Hello?
Radio.
The network is bad.
360.
Hello?
Yes. Oh, there's another voice. There's another voice. Okay, so I'm listening, please.
I was saying that the first thing we have to check is the full blood count.
Yes, I agree.
Yes, and for that one, what we expect is like you just want to know if, especially the HB, to check if you have the low white blood cell and the platelets, or maybe if there's any microcytosis like the.
Hey, there's another voice who is making things bizarre. CPD, can you mute
He has done
whoever
that.
is making the noise?
He has done that. Can I contribute?
Okay. So
Okay.
we said the full blood count. Yes, we'll do a full blood count. And what would we expect? There was noise a bit, so I didn't get the fellow very well. Full
Hello?
blood count, what will be, yes.
Hello.
Yes, we can hear you.
I want to give a try.
I don't.
So we expect to do full blood count, and from the scenario, we expect that HB should be low. Recurrent infection means WBC should be low. Then easy bruising, platelet should be low. That is what.
Exactly why. So exactly. So exactly. So what one word would you use to describe the situation? One word to describe the situation.
Pancytopenia. Mr. Alote, I think we'll be expecting to see pancytopenia.
Again, please. Please again, come again.
I said our expectation will be pancytopenia.
Please come. Please.
Hello?
I heard the expectation. I asked what? Yes. I heard everything you said, and I said perfect. And I'm asking a follow-up question. What one word would you use to describe the situation?
Ms. Alote, and there was a
Yes.
presentation that we'll be expecting a pancytopenia in this.
That's a pancytopenia. Uh-huh.
Yes. So that's
Okay.
what will be the guide for you. And then based on that, the guide from the full blood count, you
Yes.
do a smear by the protocols. So you'll be seeing what you should be expecting. You should be seeing all those cells in your film. And then
So please, what in the peripheral blood film, what would you expect to see? What would you expect to see given the scenario? All the information you have matters. What would you expect to see on peripheral blood film? Okay, so let me try another approach. Maybe by answering this very first one. So you are right. Our first point of call will be to perform our full blood count. Yes.
So in the peripheral blood, you'll be seeing lymphomas. If I come, myelodysplasia, dysplastics. No, let me go back.
Okay, so you are not wrong, but let me make another approach. Probably let me answer this one, and then the subsequent ones, everybody can come in and help. So this is how we do workup methodology. First things first, we perform counts. FVC is appointed. The information that we have concerning the patient. One of our colleagues just said that the anemia, the easy bruising, and the recurrent infections means that all those cell lines will be low. Therefore, we have what is called pancytopenia. And we know that as soon as our full blood count results are flagged, our next point of call will be to do or perform peripheral blood smear according to the standard protocol so that we don't create problems for ourselves. So we are assuming that we are doing everything right. So we prepare and stain a peripheral blood smear. So that will be the second test we want to do. If we examine that also, we might see that the numbers are also reduced on the film, because we have said that the film is a validator of the full blood count machine. That is a machine, though. So you see peripheral pancytopenia. Once you see peripheral pancytopenia, it confirms that, oh, yes, the pancytopenia on full blood counts is not wrong. It's not as a result of something we have done wrong. So once we see that both are pancytopenias, what clinical situations should come to our minds? All conditions that can present as pancytopenia, or, for example, aplastic anemia. myelodysplastic syndrome, paroxysmal nocturnal hemoglobinuria. We said that before. Even hairy cell leukemia. It was on what we did, root to diagnosis. All of these things are there. You see, everything that presents as pancytopenia plus peripheral pancytopenia should come to mind, even including drug reactions. That is why we said they will present us with every history, including drug. But here we are. They have made life very simple for us by telling of Fanconi's anemia, cytopenia. What do you look at next on the peripheral blood smear? Because of the different differential diagnoses that we have mentioned, aplastic anemia, for example, if you pick aplastic anemia, for example, what happens to the cells? Usually normal cells, except sometimes the red cell may be macrocytic. Apart from that, there will be no changes to the red cell. PNH, normal blood cells. Why? Because in PNH, distraction occurs in peripheral blood. Myelodysplastic syndrome. Yes.
Ms. Alote, please, question for you.
Yes.
If we are seeing aplastic anemia,
Yes.
is it not under bone marrow failure?
We are now looking at the peripheral blood film. We are doing workup.
Okay.
So you are jumping to bone marrow, likely things that you see. We have to see how we can make a firm diagnosis. And so we have done full blood count. We are looking at peripheral blood smear. And then we'll do bone marrow aspiration.
Is it only me now? It seems the network is very...
Cytogenetics. That is what we have lined up. We have
The
talked about this thing
bad,
before.
though.
So we are
The
going
network.
here now, looking at situation. We want to look at all sides possible. Which network is bad? Probably yours. Please, you understand what I'm saying? Because if we don't get to understand some of these things, we'll end up only describing cells, and then we'll end there. We want to bring our knowledge in hematology on board, our knowledge in medical laboratory science on board. It's medical science, all right. We want to bring all of that on board and see how it can help us make a diagnosis. And so we'll do full blood count. We are seeing all the cell lines have reduced. That is why the child is having recurrent infections, easy bruising, and anemia. And we call it pancytopenia. We are looking at the next stage, peripheral blood smear. And because the peripheral blood smear is a validator of the full blood count analyzer, we will be seeing peripheral pancytopenia on peripheral blood smear. Looking ahead, when you see these pancytopenias, there are conditions that will come to mind. Aplastic anemia is one of them. And you're right, aplastic anemia is one of the conditions that occur in bone marrow failure. You're not wrong. Another thing that can happen is myelodysplastic syndrome. Also, attributed to bone marrow failure. Extraction occurs in peripheral blood. So we are looking at the different possibilities, and then we call that differential diagnosis. So for every full blood count results that is seen, that is flagged, there will be differential diagnosis. That's like when we were classifying anemias, and we said microcytic anemia could be the tiles, could be iron, could be sudden anemias of chronic diseases. Those are differentials. And so you carry it through. Every result you look at, there's a possibility of A, B, C, D. Condition happening. It is only when you begin to examine a smear and go to cytogenetics, then you can conclude and say that because we have that and that, then we are, that's how it is. Otherwise, all we do is cells and describing platelets, and then there'll be nothing else to write. So my advice is that we go back and learn some of these things that we know already and bring them on board. All of these things now you have been taught already, these things, and then you can bring them on board. And so in this particular case, we said the differential diagnosis will be aplastic anemia, PNH, MDS, hairy cell leukemia, indeed drug reactions. And so further looking at the cells in aplastic anemia, the cells are normal. Just at times, the red cells are macrocytic. And so that is information. Red cells may be normal looking or slightly macrocytic. The white cells and the platelets will be normal morphology. In PNH, the problem is not the bone marrow. It is peripheral destruction. So as for the bone marrow, it will produce normal cells, but it will be destroyed in peripheral blood. And therefore, the cells on morphology would appear normal. If it is a myelodysplastic syndrome, then there will be dysplastic changes, as the word suggests. And so when you get there, and you say, if it's aplastic anemia, this is what might be seen. If it is PNH, this is what might be seen. If it is MDS, this is what might be seen. Then you are going through the motions one after the other. After that, what do we do next? Because we are doing a workup. After peripheral blood flow, what do we do next? Bone marrow aspirate or trephine. In the aplastic anemia, the bone marrow is hypoplastic. In MDS, it is hyperplastic. In PNH, it is normoplastic. So we are making out the differences. After bone marrow aspirate fine, what is there that we can do again? Cytogenetics. Aplastic anemia is not a clonal disease, so there will be no cytogenetic aberrations. Myelodysplastic syndrome is where you find genetic aberrations, different cytogenetic aberrations, including deletion 5q. PNH is not a clonal disease, so you may not find any aberrations. Having looked at this, we were told something in the scenario, Fanconi's anemia. Mutations in the genes involved in the FA pathway, that's Fanconi anemia pathway. And you know, from the little genetics that we know, that pathway is involved with DNA repair. So if there are mutations there, then DNA repair becomes a problem. And that problem is evidence as bone marrow failure in the individual. That is why this child has all of these things that we have talked about, the pancytopenias. And so it is the information that has been given that will make us draw a conclusion, because we have seen pancytopenia, peripheral pancytopenia, and we have looked at bone marrows, and we have looked at cytogenetics, and then we want to conclude. This thing is helping us to conclude. Therefore, that conclusion we can draw is that the person or the child has congenital aplastic anemia, was born with it. Because according to the mother, situation has been present at best. Have I made sense? Any question? Have I made sense?
Yes, please. You have.
Please.
Yes, please. Well understood.
If I haven't made sense, tell me. I have, eh? So do you see what I'm trying to drive at? Because and please, let's not think that we will be able to do everything in a lot of things on board, and so it will be a gradual process. We'll be doing evaluating films from time to time until we are able to do some of these things. Most of the time, the full blood count easily gives it away. The peripheral blood cell easily gives it away. Sometimes you need to go through some of these things and pay attention to every clinical information. That is why we need clinical information as a matter of fact. So in this situation, we are seeing pancytopenia on full blood counts. We have seen peripheral pancytopenia on morphology. What conditions do we see the pancytopenias. And then they are called the differential diagnosis. All of them come rushing through your mind. Because it is a hypothetical case, you go through one after the other. If it is a plastic anemia you are seeing, what would you see on morphology further? If it's MDS, further, what do you see? These plastic changes. If it is PNH, what do you see? If it is hairy cell leukemia, you see hairy cell on morphology. If it is drug-related, cells will be normal looking. Because if it is drug-related, it means the problem is not from the bone marrow, but it is in peripheral blood. And then we are looking at the bone marrow because that's how we do our workups. We have said that full blood counts and the peripheral blood smears that we make are what we call screening tests. And so you follow through to the next level of tests. That's why we do the bone marrow and follow into the next level of tests, the cytogenetics. If you do cytogenetics and the rest of them that are related, if you immunophenotyping and you don't get it, then you go to the ultimate, the DNA analysis. In this situation, we have been told there are mutations in the Fanconi anemia pathway. So what we need to know is about Fanconi anemia and the pathway and what happens there and how it affects us in hematology. Apart from what it does everywhere else, I'm concerned with what it does in hematology. It leads to bone marrow failure, and it is the reason that we have the pancytopenia. So these are what workups are about. Full blood count, peripheral blood smear, bone marrow, cytogenetics, immunophenotyping, fluorescent in situ hybridization, all of them are there. And then we would or might do DNA analysis if we have to. In working through all of these things, we definitely might see something that separates the cause from the others. Like microcytic anemia, and you do iron profile, and you see some iron and the rest of them are affected. Then you know it is iron anemia, iron deficiency anemia. That's for chemistry in that. And so here, it is made simple by giving us all the information in the clinical setup. In real situations, you will not get a thing like that. You have to be going through every motion. But this is a learning stage. So we have framed the thing such that something in the clues that have been given will push you to think in a certain direction. That's why we have this. Any questions? When we get to the second one, I don't like calling names, so I don't like calling names. I want people to speak for themselves. And you see, some of these things I have brought up because of the fact that when we're discussing how to make diagnosis, we said that there are things that we need: a good clinical history, drug history, what you call it, the demographics, age, a host of other things. We need all that. And so, if you have a in your lab and you are not told anything, then you are really, like I said, some of them are easily given away by what you see. Some not so, especially if it has to do with things like cytogenetics and the rest of them that are not readily available. That is why, for example, when we see proliferation of white cells in CML, we query CML because that's not conclusive. You can query CML because you are seeing on peripheral blood the presence of the whole myeloid series. And so you query, but that's not the confirmatory test. The confirmatory test is the fish and the genetics, looking for BCR, ABL, fusion gene. It is because we have been limited to just doing FBC and peripheral blood smear. Even a peripheral blood smear slowly is being taken away from us. If we don't sit up and we lose that, we'll end up being only using machines. And then when you go to make arguments, they say your work involves only the use of machines. As if you don't guide the machine, everything comes out, you give. We are too quiet. Please say something. Are we good? Are we good?
Yes, we are.
Yes, sir. Yes, sir.
Okay, I'm glad. So I'm glad. So I'm happy.
Please,
If
can
you
I
are not
ask
good, yes, please.
Okay, so thank you so much. Please, I want to find out that. So, assuming a situation like comes to me at the laboratory, am I to go through all stages such as the LBC, the blood flow, bone marrow spray, the cytogenetics, or there's a particular level you would have to end there?
In fact, I'm not getting you clear. Take your time and let it come. It's not clear at all. Take your time slowly and let it come. Yeah.
Okay, so what I want to find out is that assuming a situation like it comes to me at the laboratory, so
yes.
am I supposed to go through all this process? Like after doing my FBC and then finding out there is a pancytopenia, I go ahead to do my blood film, followed by the
yes.
and then go to the cytogenetics, the immunotyping, and all those things. Or there's a particular level you would end there to, get whatever you want from.
Oh. Once you go through the motions. You want to make it, you make. Let me tell you, most of the things we tend to end at peripheral blood smear and bone marrow, and even the bone marrow. Scientists are told that they are not supposed to be examining bone marrow. That's the situation we have. Otherwise, wherever you get to, there you can make a diagnosis. It depends on availability of the facilities that are needed. You see, it depends on. So I've just made a case for CML. You see, we are ending at peripheral blood and seeing CML. But the rich people are made to send their samples abroad to do confirmatory tests. Why? Because CML can be pH positive or pH negative, and pH negative is more aggressive. Some of these things, you see, and so they will send. You and I will probably don't know because we don't have these things available to us. At this height we are reaching, we have gotten to, we want to push it further so that policy might change and some of these things that we need can be brought in if we can make a case. So now, you and I, what we have is a full blood count machine and a peripheral blood smear, but we cannot do that are followed because we end up at full blood count. That's fine. But full blood count and peripheral blood and full blood count, what did I call them? Screening tests. And so in science, I remember when we were doing chemistry, say physical chemistry, there are tests that are initial tests and tests that are confirmatory tests. It's the same thing. It's still science. So screening tests are the ones that are available to us readily. And so we want to see how best we can use them. That is why when we see abnormal white cells, for example, that are supposed to be in the bone marrow, we want to query and suggest a bone marrow aspirate or a TREFI. You see, moving to the next level. But what's available, if you can do a screen test and do them very well and make good suggestions, and they turn out to be a right suggestion making, and it is helping. If you go and say we want to do cytogenetics, or want to do the rest of the immune phenotyping, the one that's even present in situ, blood counts, peripheral blood smear, and abnormality, they say give it to the physicians, the hematologists. Are we good?
Yes, please. Yes, please. All understood. Thank you.
Hello? 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 Sir.
And some, yeah, some of these things we would, I mean, I don't expect that after this then you are running away doing so it should be probably what we started. Yeah. Hey. Someone was
Mr. Alote is gone off because his network is scratching.
Hello.
yeah. I treat. We'll take a second question. I can get a better place. Oh. And so I have projected the second question. I'll read through if you don't see. I have on this on my and see. just please, I want to come back. I need help here so that I get a feeling that like we are following this thing, because again, if we don't bring all that we know on board, then if we don't bring all that we know on board, then all we'll be doing will be just vessels and describing players, and that having gone through school, some of these things we have encountered. And so we are just drawing on them to see how they can help us to work in the hematology laboratory to make diagnosis. And so I want inputs for this second one. A 75-year-old man presented with unexplained anemia, which had become indolent for the past 3.5 years. Someone has anemia. An old man, 75-year-old man, he has anemia, and this anemia has remained with him for the past 3.5 years. Whatever you do, it is not working. That is what indolence means. It means that you probably think it is this anemia. You are giving, say, iron supplementation, not working. B12, folate, nothing is working. Everything you are doing to improve the anemia is not working. Means it has become indolent. In other words, it has become, you see, it is refractory to treatment. It means you are dealing with refractory anemia. And refractory anemia is a myelodysplastic syndrome. And so that's how you begin to go through. So understanding the context of the preamble is the main thing. Are you hearing me, please? Am I being heard, please? Hello? Hello?
Yes, we can hear you, please.
If I get silent being heard, so there's no, there's no wrong answer. I'll be happy just to hear voices, and then we'll make interventions, because that's the way it's going to go. If you don't attempt to do the thing, I'm not sure you'll be able to do it. So you make an attempt, you make a mistake, you are told, this is it. But if you don't make an attempt to do it, and let me tell you, this, our work is a medical science. So the language we must know. It's very important that we know and understand language. I remember when we were in school, they taught us just language. In pathology, there was a topic called language. So we are learning the language of pathology. So as we go on, we must pick the bits and pieces about language. As soon as we say the thing has become the anemia unexplained, it means no hemolysis, no blood loss anywhere, but there's anemia. Meanwhile, it has become indolent or refractory, meaning that we would then cry, whatever you do about it is not correcting. And so if anemia becomes refractory or indolent, our thinking should be a myelodysplastic syndrome. So once we know it is a myelodysplastic syndrome, then we can go ahead and do the workup. So query a myelodysplastic syndrome because we haven't done anything yet. So we'll query a myelodysplastic syndrome and walk through the motions of a workup and see how it can come out with. So again, a full blood count, pancytopenia, differentials will be plastic anemia, MDS, PNH, very similar. Peripheral blood, peripheral pancytopenia, morphologies like we did previously. If indeed it is a myelodysplastic syndrome, we'll see dysplastic changes. We go through our bone marrows. MDS, marrow is hypercellular, and the other things that will come, because reading bone marrow is a difficult thing we haven't done. So I'm just looking at just cellularity. There are other things that are looked at, but cellularity is the simplest thing when you examine a bone marrow that you can talk about. So it is hypercellular in MDS, it's hypocellular in aplastic anemia, it's normocellular again in PNH. Why? Because in PNH, the distraction is in peripheral blood, has nothing to do with the bone marrow. And then we do the cytogenetics like we did before. And if we find the cytogenetic aberrations, then we know we are dealing with a myelodysplastic syndrome, because aplastic anemia and PNH have no clonality. They are not clonal diseases, and I believe we know what clonal diseases are. And so even from the history, we'll end up and give thumbs up to MDS, because the anemia is said to have become refractory to malignancy or indolence to management. And so for every workup, every test we do, that's all workups are about. Any inputs. Shall we continue? Shall we continue, please?
Yes, sir.
So there's a third question. If you can see, the full screen is covered, and sometimes if I move like this, I'll be able to read. Okay, so third question. Results of a 42-year-old woman who reported to the doctor with signs of anemia and recurrent infection is shown. And so this one who is 42 has these results. So we'll comment on the results and suggest a provisional diagnosis, after which we'll suggest further laboratory tests to make a definitive diagnosis. Okay, I have to do this. So these are the results of the, if you can see, can you? Please, can you see the results?
Yes, please.
Yeah, if you can see the results, the results, we are to comment on the results. First thing, so comment on the results first. This time I won't talk. Comment on the results and suggest a provisional diagnosis. I don't want to take out the results, so I'm reading the question. Comment on the results, suggest, like your full blood count that you have done and you have seen this in your lab. What would your thinking be? That's all the question is asking for.
Hello, sir.
We are
Please, we can see results, but we have what starts with, actually, does it start with the WB? You can't see the parameters, name of the parameter.
You can't see the parameters.
Yes, yes, please. Actually, okay, now it is fine now.
It is fine now. All right. So please comment on the results, and then we can make a provisional diagnosis. Then we'll suggest further. It's all about workups, remember. Workup lab. So comment on the results. Please comment on the results.
Okay. Can I talk?
Yeah, please go ahead. Whoever is ready can talk.
Yes. So looking at it, there's anemia, and then the white cell counts too are very high. Then suggesting that there's a myeloproliferative disorder. Then, so looking at neutrophils are high. So the first thing I will do is blood film comments. to confirm
Please,
what.
I said comment on the results. Have you finished commenting on the results?
All right.
And suggest a
So,
provisional diagnosis.
So neutrophils are high. So my presumptive diagnosis will be
Okay, so
chronic.
please let me step in once here. When you are commenting on results, it has to be orderly. If you pick white cells, you talk about the white cells situation. Then you pick red cells and talk about the red cell situation. You pick platelets and talk about the platelet situation. That is commenting on results. So like here, you talk about the red cell picture as you see on full blood count. You talk about the the white cells, and then you talk about the platelets. That's commenting on the results. And then finally, your presumptive or provisional diagnosis would come. So please start.
Okay. So the HV is low, and the red cell count too is low. The MCV is normal, so guessing the presence of normocytic normochromic anemia. Then looking at the platelet counts, platelet count is normal. White cell count is high, and then both neutrophils and then lymphocytes are high. So this one, my presumptive diagnosis will be chronic myeloid leukemia. So first, I will request for film blood comments, then to confirm the results on the film. Then after that,
Chronic myeloid leukemia is not a presumptive.
Okay.
Yes. The gentleman went off. Someone wants to pick it up from there. Another person can pick it up from there. He went off. Another person can pick it up. We should be speaking to results. So otherwise, if we are not able to do these things, that's the beginning of evaluation of films to make diagnosis. You should be able to comment on the full blood count results and presume a diagnosis. And then you do further tests that will make you arrive at a diagnosis, a firm diagnosis. Is the gentleman back?
Yes. So best.
You are back.
Even though lymphocytes are also high, but that of the neutrophil is too much. So I'll be thinking in the line of chronic myeloid leukemia.
So you query chronic myeloid leukemia?
Yes, please.
So you got to be careful with words because you say presumptive. So if you state chronic myeloid leukemia, it's a definitive diagnosis.
Okay, so I will query chronic myeloid.
You can't say chronic myeloid leukemia is presumptive.
I think I will not. I will go by abnormalities in the blood cells. So therefore, just presume.
It becomes cacophony. I can hear cacophony now. I can hear a cacophony of voices now. One person should speak at a time, please.
Okay, so as you said, so I'll query chronic myeloid leukemia and recommend further testing to confirm it. And some of the tests I will recommend will
Recommend
be,
what?
I
Uh-huh.
will recommend other tests, such as ABL, BCR fusion gene mutation.
Do you have that in your facility?
Okay, we don't have it readily available, but we outsource.
You are source. So what is the next thing you can do in your lab?
The next thing.
Workups in hematology. We just did workups in hematology.
Yes.
We are doing workups.
Okay. So this one, because I would have, if the count was not very high, I would have recommended NAP score too. But because it is very high like that, I don't know if that will be necessary.
Neutrophil alkaline phosphatase score. What would you expect the score to be here?
To be low.
Why? Someone else can help us. Someone else can help us. All of us do have to be quiet. It's got to be interactive. There is something that I'm missing. We have full black and results, and you have seen this. What is the purpose of which you are doing all these things? Can someone tell me? The reason for this
Further
weeks of
test
spending
and
2
query
hours
for
in the
diagnosis.
evening,
Further
Please come
test.
again.
Further test to help the patient.
Further test.
And then
Yes.
and then diagnosis and the
Which
diagnosis
further test?
Further tests are blood.
Please, which further test?
Blood film comment.
Yes.
Is a
So you evaluate a film. Okay, so you
Yes.
evaluate a blood film. You evaluate a blood film, right?
Yes, please.
Yeah, so what would you expect to see on blood film that will support your query, the one that you have queried? What would you see?
So I'm expecting the cause of the anemia that is causing
what would you see on peripheral blood that will bring you closer to what you have queried? Remember, someone made a certain query ahead. If you have been listening, someone made a certain query. So what is it on peripheral blood smear evaluation? What would you see on peripheral blood that would draw you closer to what you want to arrive at? So what would you see the red cells to be? What would you see the white cells to be? What would you see the platelets to be? What would you expect that these things would look like on peripheral blood smear?
So what I will see, I need to know the size, shape, and then the color, and sometimes abnormalities of the RBCs of the smear, and also look at the white blood cell type, like neutrophils, lymphocytes, and then their morphologies. and then the platelet count as well on the blood smear that I prepared.
My question is not answered, please.
So, Mr. Alote,
Please.
Yes.
so I'm examining the flame. I expect to see a preponderance of myeloid cells, matured myeloid cells, such as neutrophils on the flame. And then with the RBCs, I will also check and sometimes I see normal blasts, a few normal blasts. And then check for the presence of basophilia.
The presence of what? Basophilia. Hello, Ms. Alote.
Yes, say
Please, I
something, my
want to
dear.
try.
Yeah.
I'm thinking that when I prepare the film, I'll do a corrected WBC count with the film. Maybe there could be a lot of nucleated RBCs that the analyzer is picking as WBC. So I'll correct the WBC, do a WBC count. Before then, I'll look at the RBCs and then the platelets.
So
The
if you look
sizes
at
and
the
the shift.
RBC, yes, if you look at the
So for the
RBCs, for example, if you look at the RBCs, for example, what would be your expectation?
So for the RBCs, I'll see a lot of I'm expecting to see some retics there because from the MCV is normal. So there will be some normal RBCs there, but there will be some retics there as well.
Why would there be retics?
It's because
For
of
the
the
Why
RBC,
would there be retics?
there are young cells that are being
for the
produced
I'm
into the
asking why
platelet.
you think there will be. I know
So there
retics are
could be a
young
problem
cells.
with the bone marrow. That's why you are having. There could be a problem with the bone marrow. That's why we are having a lot of retics, and the retics are not maturing to the mature RBCs. That's why I think. Say.
We haven't seen retics. We haven't seen retics anywhere.
In the FBC. But I am thinking that when I look at the film.
When you examine the film, you expect to see if indeed there are retics. If indeed there are retics, what on full blood count would you see that will tell you there are retics? A lot of retics.
I think the histogram will help with that.
Okay, now there's no histogram. There's no histogram there. We have full blood count results. Your full blood count machine, do they give all of them? Do they give you histograms? All your full do they give you histograms? If they give you histograms, fine. Remember one of our
Ms. Alote,
colleagues.
For me, I will see the variations in the RBC sizes, that the anocytosis.
I don't know which question you are answering now. Which question are you answering now? I don't know which one.
Concerning the RBCs you're talking about.
The retics you're saying.
With this result.
And so when you examine the film, you expect to see retics.
Variations. I will see the variations in the RBC sizes because of the anemia deficiencies in that. So you see inocytosis, and then also see a variation in shapes as well. That will be variations in RBC shapes as well.
So what shape of RBC would you be seeing?
I'll be seeing inocytosis, and then
What? Shape of red cell, which one will you be seeing? Are you seeing sickle shape, or you are seeing acanthocytes, or are seeing echinocytes, you are seeing codocytes, or you are seeing which one? Which shape?
You may see elliptocytes.
Anybody else?
MVCR.
From what? Oh, the voice went dead. Master, please come again. The big man went off. So, it's not only me who should find a tree to stay on the tree. Other people too should look for trees, because the internet is also going off. Just by the way, I'm listening. Any more inputs?
Emmanuel Seboaba. Emmanuel Seboaba. Emmanuel Seboaba.
Hello, Doc.
Please come in. Come and help. We are listening to you. Talk.
Doc, please, I'm trying to multitask. I'll define this one and then I would come in late. Doc, with all due respect, sir.
All right, sir.
Thank you.
Please, I'm waiting.
Emmanuel Adongo. Emmanuel Adongo.
Hello.
Are you there?
I'm there.
What do you say about the results?
My challenge is I can't see the figures very well.
You can't see them?
Yes.
Okay, all right.
Very sorry.
Very sorry.
Whoever can see should help us. We want to see whether we should end with this, because the time is fast spent. So we should be able to use
Daniel Seru. Daniel.
Bend out the time
Yes,
to deal with this.
Yes, Doc.
Can you help? Can you help?
I find it difficult to read though, but what I can get from it is what I'm putting up, that the RBCs that we are seeing, there's a variations and the RBCs. That's what the sizes. That's what you may expect on the film because of the deficiency in the anemia. So for that side also, the shape as well on the RBCs. You can also see the shape variations, and then the indicating of an iron deficiency. Probably I can see the hemoglobin level is 6 point something or so. If you can mention it to me, I'm seeing 6.1 or 6.2 or so. That is what I'm seeing.
Thank you very much. Thank
And
you very
then you may also see hypochromasia because of the RBC being pale. Unless the film is, this is what you are guessing by, unless the film is prepared before you can actually say something. So this is what I can say for now.
Thank you very much. Surprisingly, none of you is commenting on the size, the red cell size. MCV. Surprisingly.
I commented
So,
on the RBC size, indicating, I commented on the RBC size.
based on the size, the MCV is normal.
Yeah.
MCV is normal. MCV here is normal.
Yeah.
Yes. So if it's normal, what is it?
The MCAC, normocytic RBCs. And then the MCAC and the MCH are both normal. So I expect to see normochromic RBCs. But looking at the RDW, it is high. So I expect to see variations in the size of the RBCs.
And then what else? What about WBC and platelets?
I thought we already spoke about the WBC. Okay.
Yeah, we are commenting. You are commenting, so your commenting should be holistic.
Okay. So for platelets, they are normal, but the black so then the WBC very high. So I expect to see many of them on the screen. Then the full blood count also shows neutrophils are the majority. So I also check to see a preponderance of matured lymphocytes, neutrophils on the food. Then lymphocytes too are high. So I expect to see them to also be slightly high compared to the neutrophils.
It's not a problem. Not that so descendants to be responsible. So descendants are always in construction with you.
I have to this thing one. How is the way of this one? Let's put some.
Hello, Dr. Lotte. I think the landscape view of your slide was way better.
Say again.
I'm saying the landscape of your slide was way better than the portrait one, because with the landscape, it zoomed better, and then we were able to see all the parameters, including the reference ranges. Exactly, say.
Now it's
This
good.
is fantastic. That is fantastic.
Yes. This one is fine.
Also, you shouldn't zoom too much. I think with the normal zooming, it was fine.
I think it's fine now.
It's okay. Is this okay?
Yes, this one is okay.
Yes, very, very good now.
Okay, so now I want you to talk because we have barely 10 minutes. Otherwise, it will be giving us an assignment.
That will be fine. And then let me just add up. Somebody want to talk? And then let's see.
Hello, Doc.
It's very blurred.
Hello, Doc.
We are listening. Please
We are
talk.
listening. We are listening.
Yes, please. So I want to find out, are we still trying to, should we still comment on each, or we should bring out a presumptive that is like you said?
But we are trying to answer a question. We said comment on the results and suggest a provisional diagnosis. And then we'll also suggest further laboratory tests that will lead us to make a definitive diagnosis. We are still doing workups in hematology. Don't forget what workups are about. And we have looked at two different scenarios. This is the third scenario where we have presented actual results. And so after commenting on results, you give us a presumptive or a provisional diagnosis. If you see this in your lab, what would your thinking be? And then what next would you do? And then what next would you suggest to be done if you don't have the capacity to do it? That's what workups are about. We have told you over and over again, screening tests, confirmatory tests, etc., etc. You know. So once you comment on this results, red cells, white cells, platelets, you want to see, or you want to tell us your expectation when you examine a peripheral blood. Is it going to validate the results, or is it going to abandon the results? Assuming it's a true reflection of what is going on, what would you expect to see on peripheral blood so that it validates the full blood count, analyze the results, says yes, what is a full blood count is correct. What would you see for red cells, for example? What generally would you see for red cells, for example? What would you see for the white cells? And what would you see for the platelets? Someone attempted to speak, but it's like a cacophony. I didn't hear. any help. I'm not getting the help I need from participants. I'm not getting it. It's not interactive for me at all. It is not. Again, the
Hello.
yes.
Okay, so I want to come in.
You said
I want to bring my suggestion. Okay, so like you said, assuming everything is normal with this patient, so under the film comment,
I didn't say that. I didn't say that normal with the
now,
patient. What we are seeing is not a normal situation. So I
not
couldn't
that
have said no.
assuming this is
What we are seeing is
reflection of
not a normal situation. I couldn't have said normal.
I'm trying to say, assuming this is a correct,
A
a
true
reflection
reflection of the patient. Yes. What do you expect to see on
on the
peripheral
film
blood?
comment. So
Yes.
in the peripheral blood, I expect that there should be pneumochromic cells and then
Okay,
pneumocytic.
normocytic pneumochromic red cells. I agree. Second one, white cells.
With the white cells, I expect to see increase in the neutrophils and relatively increase in lymphocytes too. Giving yes, so with this, it is giving me an indication patients might be having some bacterial infection or probably viral infection or a mix of the two.
Why did you choose to talk only about neutrophils and lymphocytes when there is basophilia and then there's eosinophilia? And also monocytosis. Why have you decided that they don't matter? Why have you decided they don't matter?
It does.
Basophilia, eosinophilia.
Yes. And then monocytes to an increase in size.
So why are you not minding them? As if they are not there.
You are right, sir.
Have you heard of any bacterial infection that will give you a white cell count as high as 406 times 10 to the power 9? Have you heard about a bacterial infection like that?
No, sir, but then looking at it from the fact that when there's an increase in neutrophils, probably there is a presence of bacteria. That was why I was suggesting there could be a bacteria and then viral infection. But then, like rightly said,
of course, the person is getting recurrent infections already. In the story, in the preamble, with signs of anemia and recurrent infections. So we have been told already. So if you say bacterial infection, we have been told already the person is getting. So what you need to be thinking through is why the person is getting bacterial infection. You get it? Why is the person getting recurrent infections? It's a why you should be talking about, because you have been told already that there's recurrent infections and there is anemia. So why would the person be getting recurrent infection? It means the neutrophils there are not functional. They are just there. They are not functional normally. And so you can think about something happening in the bone marrow where the production cells are there, but they are ineffective. They are not working. And then when you look at the different cell lines all present, it gives an idea that it's like every cell is present. A high white cell count with all the cells being there. Of course, the lymphocyte is also there a lot, but relatively lower than the myeloid cells, the neutrophils. But there are other myeloid cells there. All the myeloid cells appear to be there. Basophils are there, eosinophils are there, neutrophils are there, even monocytes are there. And I was happy when someone queried CML from the beginning, but nobody is trying to speak to it, speak to that. Querying CML. If you query CML, what do you see on peripheral blood? I keep saying that. What do you see on peripheral blood? I agree with the fellow when the fellow said, I'll query CML. Okay, query CML, fine. So what do you do next? And then we entered into this. We should have ended long ago. When one person said they will query CML, and I agreed, we should have followed up on CML, would have finished by now. Only the person, instead of saying we'll review a peripheral blood smear and see so and so and so and so, the person was talking about BCR-ABL transcripts. So I asked whether they have that in their facility. Then he said he will outsource it. I said we are doing what we can. We talked about our screening tests. That's what we want to do. Full blood count. I even asked the purpose for which we are having this discussion. We are doing a course on blood film comments. And instead of telling me you evaluate a film, someone was about BCR-ABL transcripts. And so I asked whether you have that in your facility. And they say, oh, we will source it. And then suddenly no one is talking about that any longer. And we have said over and over again, if your full blood count results are deranged, your next point of call is the peripheral blood smear. Hey, someone is singing, someone is playing music. Yeah. One said he will query CML, and I thought he was going to follow through. He said he will do the fish and DNA analysis. I said, what is the next thing available to you? Why are you not doing that? But rather go and outsource this. And I made an example that even for us in Korle Bu, we were not doing some of these things. The next thing we do is to do a smear, a thin film, peripheral blood smear, followed by a bone marrow. And then if you can outsource the the genetics. You don't have it and you outsource it. But most of the time, the film and the bone marrow are sufficient for making some of these ones because they are easy to make. But then when it comes to treatment and management, they would want to do some of these things. Like for CML, you want to see whether it's Philadelphia chromosome positive or negative because it has an impact on management. You see, the negative ones being more aggressive, more difficult to treat. So like I said, we need to bring all the things we have been taught along the line, bring them on board, harness them, and be able to use them to our advantage. All the things that we have learned along the line. This is not the first time we are hearing about CML. It is not. And I'm sure if we need to ask about CML, you'll be speaking a lot more than I can manage. So bring all of that knowledge on board, and then we'll be good to go. And don't forget that workups in a hematology setup begins with your full blood count, followed by evaluation of a film. We said that when we did route to diagnosis. Depending on what you see on peripheral blood, it serves as pointers to what can be done next. Here's a case we have full blood count result. What do we expect to see on peripheral blood so that it tells us that, oh, the full blood count result we are seeing is not faulty. It's not because someone has done something wrong, but it's a true reflection of what we are seeing. And so for a case like this, we'll be seeing normocytic normochromic red cells. After all, MCV says no. MCH, that gives color. And we said the MCH is the one that gives color to the red cell. Amount of dry hemoglobin in a unit cell. And that gives the color to it. So we see normocytic normochromic red cells, not bad. We see white cells markedly raised. They are really high. In fact, in the days before analyzers became common, if you had a situation like this, you not be able to even count. You have to modify your dilution factor before you can count. You people are blessed. You have machines that can count any number, of course, depending on the limitation of your analyzer. But there are analyzers that can count any number of white cells. And so white cells will be markedly raised. And then you begin to see the different cell lines. And if indeed you see what is described as a whole spectrum of myeloid cell series, then you're looking at a CML. Monocytosis is likely because on monocytosis on the full blood count, you may not even see monocytes on peripheral blood. The monocytosis on full blood count is as a result of the fact that the analyzer has determined the primitive cells as monocytes, myeloblasts. Myeloblasts, they will scatterize the same way as a monocyte. After all, a monocyte is a large cell with a large nucleus. So these are the things that we know already that we expect And that's knowing your analyzer and knowing the limitations of your analyzer and all of that. Was why I asked a colleague to tell me what bacterial infection you are seeing. That white cell count is like this. Something has gone wrong in the bone marrow, and it is multiplying like my old boy would say, bone marrow has gone mad. It is producing white cells like nobody's business. You know, there's a problem with the kinases that are responsible for this Janus-associated kinase. And kinases are enzymes that build. And so your enzymology will come into play. They build, so they are building, they are proliferating, they are multiplying like nobody's business. And it is why hemoglobin is low, because hemoglobin red cells are being crowded out. Red cells are being crowded out. They are not able to come up because the white cells are too many. That when you see them, if you see a marrow like that, you see it's crowded with white cells. So red cells don't get the chance to develop. Hence the low hemoglobin. I think we have traveled too far. Any comments so far, so that we have traveled? We are past 9:30. 10, 11 minutes past. So again, we need to bring knowledge to the table. Otherwise, all we'll be doing will be describing cells. Red cells are this, white cells are that, platelets are that. Then we are done. We are not able to see anything else. Thank you. CPD, I'm done.
Thank you, Mr. Aloti. It's late. I think we can retire. And so if there's nothing more to be added, we'll just close the lecture. Thank you.
Yes, I'm done. So if colleagues don't have anything else to add, then we'll call it a night. Victor, do you have anything to add?
No, please.
Emmanuel, you have something to add?
I'm okay, sir.
No, please.
We have plenty Emmanuels on the platform.
I'm talking about
Emmanuel.
The one knows himself. The one I'm calling, he knows himself. He's not speaking. He knows himself.
No,
Yes, and he wants to speak now.
Yes, please. Nothing for now, Doc. Thank you.
Okay, so then good night and thank you for listening. I hope you know, I whipped up your interest a bit. As for us in hematology, we can't help it. We must know a bit of everything to be able to function properly. If we don't, we are in trouble. We are in big trouble. So we mustn't forget a bit of everything, a bit of chemical pathology, of pathology itself, of immunology, of chem path, what have you. the microbe, everything. There are viruses in that are very important for us in hematology. We deal with parasites because of the anemia they can cause, hey, mosquito. All right. So thank you for listening.
Thank you very much, sir.
Thank you. Good evening.
Mm-hmm.